for those who couldn't register in time for the webinar. So welcome to all of those who are joining momentarily. I can see the number of participants increasing bit by bit, and welcome to all those who are on YouTube as well. So I'm Asha George. I'm a professor at the School of Public Health at the University of the Western Cape, and I've worked on gender issues in health systems for over 20 years. And I was really struck that this issue, in a literature review that I did a long time ago for WHO, there was beginning to be some attention to this issue. And there have been a few of us who have been sort of highlighting that this is the most extreme form of gender discrimination in the health sector, and it needs further attention. Last August, there was, many of you may know, there was a medical doctor, a trainee in West Bengal, in a hospital, who was murdered. She went to rest. She was on a night shift, and she went to rest in her hospital, and she was raped and murdered, and they found her body the next day. That has led to outrage and a sort of reprioritization of this issue, even though several of us have been trying to flag it as key. And there was even a Lancet commentary. So I think it's timely to come back to using the momentum and the outrage that was expressed to look more systematically across our contexts on what can we do, how do we work collaboratively, and what does it look like in each of our contexts. And that's why we're really excited to have this webinar, where we'll be hearing more from colleagues in South Africa, Tanzania, and Burkina Faso. Let me hand over to Arthur, who will introduce himself. He's our colleague from UNU IIGH. This is part of a series of webinars that we've done together between SOPH, the African Union, and UNU IIGH on a community of practice on gender and health. And we're really delighted to have this deep dive to really look at diverse experiences across Africa. Over to you, Arthur, and thank you everyone for joining.
Thank you so much, Asha. Thank you for starting us off with those kind introductions. So my name is Arthur Saitabau Ngetich, and I'm a postdoctoral fellow at the United Nations University, International Institute for Global Health, UNU IIGH. And it's a great honor to be here moderating this webinar and engaging with you all over the next about an hour and a half. We have an exceptional panel of speakers lined up, and I'll be introducing them shortly. But first, let me just go over a few housekeeping items, which I believe have also been posted in the chat. But just as a reminder, kindly note that the webinar is being recorded and live streamed on UNU IIGH YouTube channel, and you can find the link in the chat. And in addition, we're also providing French translation for today's session. So if you like to use it, simply click on the interpretation icon at the bottom of your Zoom window. And I believe a screenshot of the same has been provided in the chat. And in case you have any questions or recommendations, please use the Q&A function. We'd also like to thank all those who submitted questions during the registration process. So for me to just set the stage for a discussion, I want to emphasize that today's focus on gender workplace violence in the primary healthcare workforce is really aligned with the 16 days of activism against gender-based violence. And this is a campaign, as we all know, to raise awareness and drive action to eliminate all forms of violence against women and girls. And our session today is specifically aimed at highlighting the critical importance of investing in research to better understand the underlying drivers of violence against women, particularly within primary healthcare workforce in Africa. So as a start, it's important for us to understand what exactly constitutes workplace violence and how widespread is it. So just moving to the next slide. Just as a highlight of what workplace violence encompasses, this really constitutes a wide range of harmful behaviors, including physical, sexual, verbal, and psychological abuse. And it basically refers to any incident where employees face harm or threats related to their work, whether at their workplace or during their commute, impacting their safety, health, and well-being. And specifically in the health sector, perpetrators of such violence can include community members, patients, visitors, colleagues, and even supervisors, among others. Important for us to recognize that violence against female health workers, as Asha mentioned, is an extreme form of abuse of power within the health workforce. And to just illustrate the extent of this particular issue, we picked on a global systematic review, which reveals that close to nearly 62% of healthcare workers have encountered some form of workplace violence. And among these, non-physical violence is the most common, with verbal abuse affecting almost 58% of health workers, followed by threats and sexual harassment. However, it is important to recognize that these figures are likely underestimated, as many incidences go unreported. And also important for us to keep in mind that health and care workers are also responsible for managing and responding to cases of gender-based violence. And therefore, this dual burden not only heightens the exposure to workplace violence, but also highlights the critical need for systematic solutions to protect the well-being of healthcare workers. And now looking specifically at the African region, as we are well aware, the primary healthcare workforce is the backbone of a strong health system and is quite essential for us achieving universal health coverage. And one of the most pressing yet often overlooked issues in the gendered nature is the gendered nature of workplace violence in the primary healthcare setting in African countries. This violence really reflects the deep-seated gender and power inequalities that disproportionately affect women, who are often at the front line of healthcare delivery. And this particular figure shown here provides a snapshot of the three case countries for the webinar, that is Tanzania, Burkina Faso, and South Africa. And we could also extrapolate this to other African countries based on the different experiences. And our speakers will share insights on the magnitude of this form of violence and what works within the existing legal protections and formal policies. So I won't really go into this, but allow our panelists to shed light on the different country contexts. So now moving on to our webinar objectives. First is for us to explore the drivers of gendered workplace violence in African contexts through shared practical experiences, focusing on how structural gender and power dynamics contributes to this issue. And secondly, we'd also like to just have a discussion to establish a research agenda that informs evidence-based strategies to address gendered workplace violence while exploring the practical ways to support and protect PHC workers, especially in the African continent. And before I introduce our speakers for today's session, we'd like to just remind everyone that this is the second part of a two-part webinar series. The first session focused on policy frameworks for action towards addressing and mitigating workplace gendered violence in healthcare settings. So if you missed this particular important discussion, I think a link has already been pasted and provided in the chat for the recording of this particular webinar, first part of this webinar series. And so now, without any further delay, I'd like to briefly introduce our esteemed speakers for this session. And for more detailed profiles, please check the chat. So we have with us, I think Professor Asha George needs no introduction. She introduced herself and she graciously opened the session for us. But just to mention that she's a qualitative researcher dedicated to advancing health and social justice through health systems research. She holds the South African Research Chair in Health Systems Complexity and Social Change at the School of Public Health of the University of Western Cape. We also have with us Dr. Vera Scott, a senior researcher, also with the School of Public Health at UWC, and an area manager in Cape Town with years of experience in advancing health equity and strengthening health systems through her work on social determinants of health and governance in decision-making. We also have Dr. Sally Mtenga, the head of Health Systems, Impact Evaluation and Policy Department at the Ifakara Health Institute in Tanzania, and she specializes in social science research on gender, health risk behaviors, and the influence of social norms on public health outcomes. And last but no means least is Dr. Mamadou Ouattara, a medical doctor and research associate at the National Institute of Public Health in Burkina Faso. And his expertise spans epidemiology, clinical trials, and reproductive and maternal health research. So with those introductions, I'd like to just invite Sally to give a brief presentation and help us explore and understand how research can be leveraged to address gendered workplace violence in PHC, considering a Tanzanian perspective. Over to you, Sally.
Yeah, thank you so much, Arthur. A pleasure for me to contribute to this important topic, very relevant and timely, not only in Tanzania, but in Africa at large. So next slide. Next slide, please. Yeah, so setting the context for my contribution. You have jumped the slides. Yeah. So setting the context for my presentation, I would like to highlight that indeed, and yes, in Tanzania, we have made very important steps in addressing gender-based violence, especially against women and children. And we have received quite a number of support and a lot of initiatives coming from the Ministry of Community Development in collaboration with the Ministry of Health and the other stakeholders in the country, being somewhat supported by the development partners. We also receive political and policy support. We can see that our Tanzanian Vision 2025 also emphasizes on human-centered approach, and they recognize gender equality as an important aspect. And also our health sector strategic plan 2021-2026 also emphasize very important critical pillar. Gender is a very important critical pillar to achieving universal health coverage. We have witnessed a number of progress, especially when it comes to secondary school enrollment for girls, and the female labor force participation has also increased, and also women participation and decision-making at different levels, including at the national, community, and household level has also increased. We have witnessed a number of legislations being modified or adjusted to be able to address the issue of gender-based violence, especially in workplace. But however, besides having all these kind of important development, the issue of gendered workplace violence remains silent in the country. We have very limited initiatives to address this, despite having had some instances of sexual harassment in public health services. Also, the issue of gendered workplace violence, it's not linked to healthcare performance measurement. We have very limited indicators to measure the progress towards gender-based violence that includes and appreciates the issue of gender workplace violence. And so far, we have very limited urgency and interventions to address the issue of gendered workplace violence in the country. Next slide. Yeah, just to highlight that we are very much pleased and we are very much proud that our country, we have been able to achieve 37.4% women representation in the parliament, and our parliament is being led by a female speaker, Honorable Tulia Ackson. This is a great achievement and we are very much proud of that. However, just to emphasize that there has been very limited translation of all these legislations that I have mentioned into actionable research and health workforce interventions. Next slide. So actually my task is just to provide some key highlights regarding what we need to embark in relation to research in order to address or improve initiatives on gendered workplace violence. And one of the issues that I was thinking is that we really need to come up with very strong evidence that provide information on the profile and the categories of gendered workplace violence within the health sector. This, unfortunately, has not been conducted, especially in our context. And also, we need to conduct implementation research to develop inclusive interventions to address constraints faced by women in the health workplace. And also, we need to strengthen women's voice and urgency to ensure effective strategies against workplace violence. We also need to explore legal, social, and governance factors that may contribute towards sustainable prevention of gendered workplace violence. And another aspect is that we need to integrate specific indicators in the routine National Health Information System, because so far the indicators that we have, they are very limited. They only provide an update on the extent to which the country has been able to address gender-based violence. But gendered workplace violence, some indicators in relation to that, they are missing. Next slide. So with regards to the way forward, we are thinking that we really need to invest on structural reforms, because individual interventions have very strong limitations, because the gendered workplace violence is entrenched within some social norms and the structural aspects, which may take a lot of time to deconstruct. So we need to come up with structural reforms to be able to address the gendered workplace violence. And one way is to improve women's professional development and empowerment plans, also increase legal enforcement against gendered violence in healthcare, in health workforce, also translation of the available policies and the legislations into practical actions at primary healthcare. And we also need to invest on professional and remuneration promotion plan for women in the health workforce, and also increasing awareness about gendered violence in primary healthcare, because so far there is very minimal advocacy on this area, which is really important. There is very limited discourse around gendered-based violence. That's the end of my presentation. Thank you so much.
Thank you so much, Sally, for those insights. And without taking much time, I'd like to just quickly bring on Mamadou, and building on that, Mamadou, if you could just help us understand what gendered workplace violence in PHC looks like in the Burkina Faso context. Over to you, Mamadou.
You, Arthur. Sorry. So thank you, Arthur, and good morning, everyone. Next slide, please. So in the situation of Burkina Faso, you know that there were kind of a gender balance between the male and female working in the healthcare setting. We were close to 52%. That was last year. And this year, when we look at the national figures, we have already 56% female healthcare workers in the working in Burkina Faso. And there is one region actually, which is the central region, which is like of the capital city region, which has like 71% of female healthcare workers. The next slide, please. So at the legal framework issue, so what is in Burkina Faso is that we have legal protection under the law 28. So you have the article 36, 37, and 38. Actually, the 36 say that employers might ensure hygiene, safety, and treatment with dignity in the workplace, including for females, and any kind of physical or verbal violence or other abuse. And in this abuse, they also included sexual harassment is forbidden. So the 32nd also, 37 came onto sexual harassment that is explicitly forbidden. And when we went to the the penal code, actually it's even punishable with 1 to 3 years imprisonment. So there is also any kind of discrimination based sexually is also prohibited in the working place. So this is generally, but when you look at what is ongoing actually at the healthcare setting, so all the services are supposed to come up with an internal rules like a code of conduct that are actually not in place. So you will realize that in Burkina Faso, most cases for violence that occurs are verbal violence, sometimes physical, but there are actually no internal rules, so reporting are also low. So mostly individuals will just go to the managers and they try to set violence issues at with the community, but rare cases will go to the next steps. Next slide, please. So, and you know that Burkina Faso, we've also two other regions of West Africa is facing increasing insecurity since 2016. So this has also added another aspect of the violence in Burkina Faso against healthcare workers, especially at the primary healthcare setting, with actually security incidents occurring. So in 2013, reports for public health facilities say that we had 39 security incidents in healthcare hospitals, and 20 in which that the armed groups destroyed or take the materials. And sometimes also we have healthcare professionals who are kidnapped, and unfortunately we have 8 that are killed. So the issue here is that this insecurity has come, and then mostly female healthcare workers who used to work in insecure conditions, actually, most of them are relocated at bigger cities, and this is also impacting the performance on the work setting. Next slide, please. So what is actually known in Burkina is that in Burkina, there is actually no much known about the magnitude of workplace violence targeted to female healthcare workers. So, but you will see that mostly if you check Facebook or the local media online, you have some cases of violences against female healthcare workers. So one of the cases actually that I brought here is that it was one female healthcare worker. She's a midwife, and she was actually beaten in a village because patient relatives were not happy with her behavior, saying. But what is also good here is the important role played by social media in promoting such violences in Burkina. So these are the comments. So we can see the three comments. I'm sorry for the names, but you have 2 comments actually, which are promoting the violence in the towards healthcare workers. So they say that the first one say that their healthcare workers are rude, they have no respect for patients nor his families, and they are not well educated, and some of them deserve to be beaten. The last one say that he thinks that also patients have the right, and that he was also acknowledging that he has seen a hospital being burned by users in the city of Bobo because the people feel that the healthcare workers were not behaving in the good way. But the issue here is that mostly it's female. The last one actually which got to the judge was at Ouagadougou. So we were one guy who he lost his wife during operation. So in the operation theater, but the operation was done mostly by males. But he followed one nurse, one midwife, and injured him. So she was lucky because he took a knife, but she was bleeding and she was took to the emergency room, and luckily she was saved. This is the only case that we know that has been to the judge, and they also got sentences for the patient and his family. So this is the role of social media played in Burkina Faso in a context where we don't know actually what is the real magnitude of healthcare violence toward female healthcare workers. But from my experience, you know, the female healthcare workers in Burkina, they are mostly nurses and they don't have a decision position, and they are in front. And there are a lot of kind of abuse that they went through, but they cannot report because they are also, if they report, they are blamed either by the managers or by the community. So thank you, Arthur.
Thank you so much, Mamadou, for those insights. And I think we'll come back to those, just you painting the realities in Burkina Faso. Thank you so much for that. And I'd like to just bring on Vera, considering, with the Tanzanian and Burkina Faso context highlighted, we'd also love to hear your perspective on how workplace violence is gendered and how it manifests in South Africa based on your experiences. Over to you, Vera.
Thank you very much, Arthur. And it was fascinating to hear the descriptions of the gender-based violence experienced in Burkina Faso and in Tanzania, because there are a lot of similarities with what we experience here in South Africa. I'm going to speak from the perspective of an operational health manager and somebody who has a background in health systems and policy research and design. It's been fascinating for me the last 4 years to have made the move now to operational management and to experience on the ground the sorts of conditions that healthcare workers face on a daily basis. The particular setting that I work in is rendering service to a community of about 1.4 million people. And it includes Khayelitsha as a sub-district where there's an extremely high level of unemployment and poverty, and a mixture of formal and informal housing. What's important is that within that setting, within the community, violence is endemic. If we look at the number of murders, the number of rapes, the number of car hijackings, we see that they're among the highest in the country. So within a setting where there's violence, what we find is that health workers are not spared the violence. And I think that's an interesting reflection in terms of where we've come from in the past, where healthcare workers were extremely respected within their communities, and where there was a level of protection given to healthcare workers. And so the increase in violence is possibly, and I would love to hear others reflect on this as well, possibly related to how health workers are perceived by their communities. And Mamadou, that's maybe a conversation that we can have, having heard your presentation. The majority of healthcare workers are women. So it's not surprising that women are affected more than men because there are more women. But is it just that? And I would argue that it's not. We also find ourselves in an extremely patriarchal society. And so women are targeted more than men. And this brings me to the experience of workplace violence. So the particular example that I'd like to put on the table is that of environmental healthcare officers. What's interesting about their workplace is that it's only about 25% of their work is done in the office, in a building. They spend a lot of their time in the field. And that's the nature of their work. So their workplace setting is different from that of a clinic, where there's at least a building that offers some protection, and security can be placed at the entrance to the building. And we have a lot of policy around safety in the workplace that applies to building settings. What's also interesting about this particular cadre is that it is a cadre that used to be male dominated, but that has changed. And in fact, the teams that I now work with are predominantly women and predominantly younger women. So their work requires them to visit premises that sell food and to do inspections to see whether or not a certificate of compliance can be given to the facility, to the trading premises. If they don't give that certificate, it actually has an economic impact on the client that they're serving. Now, our approach is to work with clients to build up their skills so that they meet the standards. However, there's actually conflict inherent and a power dynamic inherent in that relationship. And this is where we begin to see the gendered nature of violence, in that we have a situation where within society, women still face a lot of harassment. And so you put a young environmental health officer in an inspection situation where she now has power to decide, but there is then conflict created, and the pushback is often in the form of sexual harassment through intimidation, through innuendo, and that is a constant experience for these young women. So much so that it's normalized within the workplace setting. And I wonder as well whether it's not perhaps normalized because it's been a male-dominated profession. And so as a profession, there hasn't been thought to what happens when women enter that space. And of course, women want to be able to demonstrate that they are just as good as the men and are able to do that job. And of course, they are able to do that job. The question is, what support do they need? And is it the same? And is there additional support that they require? Certainly, I would think that normalizing the harassment is not an appropriate response for us as the health system, as we are trying to build the well-being of our workers. So I think that for me is just one of the examples where there is a particular gender dynamic taking place. It's one that's reflected from what's happening in society as well. Yeah, I think maybe that's where I'll stop for now and look forward to the discussions that happen in the panel. Thank you.
Thank you so much, Vera. Thank you so much. You highlight, quite important issues for this particular discussion, and I think it's clear that, as you say, violence is quite endemic within the community and does permeate the inner settings, and it predominantly really impacts women and women healthcare workers for that matter. So Asha, I'd just like to bring you on at this point, and drawing from what Vera mentions as patriarchy and power imbalances playing a role in this. I was just reflecting on your published analysis that describes violence against female healthcare workers as a tip of the iceberg of gender power imbalances. Could you just elaborate on the role of structural gender and power inequalities and how the role they play in permeating workplace violence among frontline healthcare workers? Over.
Thank you. Thank you, Arthur. And I think our panelists have begun to shed light on how violence against health workforce, the violence against health workers, and particularly female health workers, has different elements of inequality tied into it. So although a lot of the studies focus on physical and verbal violence, and violence as a direct act needs to be prevented and addressed, it takes place within a broader social context. And I think in our commentary, we used feminist analysis to unpack what were the structural drivers that underpin the vulnerability of female health workers. And one is visibility. And I'm struck by, there are 2 posts in the chat of the challenges of getting permission to do this work to improve documentation. There's actually massive underreporting and very heterogeneous. If you try and do a review, the studies are very heterogeneous in terms of how even the scientific data, the studies that are able to be conducted are very uneven in the way they've done sampling, which health cadres they involve. But even thinking about, it's taken 20 years to improve our measurement of gender-based violence at population level. we need to take those lessons into the health workforce. We haven't done that really systematically, and use those lessons of how to do research of this kind. Not only is there underreporting, but colleagues have to report to mechanisms where it might be their seniors that are the problem, and therefore the mechanisms are not necessarily safe places for those at a junior level to report these problems. So what is known, that's one part of the structural sort of inequality that blocks us from understanding the range of experiences and the extent of experiences and by whom has those experiences. The second line of analysis is who has what. And I think we need very tailored, contextualized approaches to what does safety look like and who are the health workers. And you began to see that a little bit, the way in which Vera talked about the context of environmental health officers in Kailicha. It's very different from nurses in Burkina Faso and PHC health workers in Tanzania. They may have common elements of inequality, their health sectors that are under a lot of constraints, but we really need to look at in each context, who are those health workers and do they have the ability to report violence? Do they have the systems of support and systems of prevention? Across all these different sectors, it's women who the health workforce has the worst gender pay gap across all sectors. And we have to understand that your ability to speak up against violence is much less when you are you're at the lower end of the health workforce, you're more prone to experiencing violence, and you're really dependent on that paycheck. In many countries, community health workers barely have a living wage, and yet they're very exposed to violence. What basis do they have to speak up against their superiors when they're really dependent on that paycheck? And this comes back to who is valued, the recognition of women's role in the healthcare workforce. It's sort of historically, subordination is built into the health workforce by the way in which we have occupational segregation. And historically, we have women's professions being subordinate to male professions. And that makes it harder. It's sort of normalized. Vera said violence is normalized, but inequality is normalized in the health workforce, and that needs to be addressed. And that comes to that last point on who decides. Really, very few women make it to leadership positions. And when they are in leadership positions, they're neither supported or held accountable to really take forward more gender responsive policies that address these structural drivers. So we need to address the immediate acts of violence and ensure safety in the health workforce, but we also need to look more broadly and looking systematically, what are the vulnerabilities that make it harder, that make certain health workers that are usually female more vulnerable, but also less able to raise their voice and really mobilize to come up with local solutions to address safety. Thank you very much.
Thank you so much, Asha, for those great insights. And I think I'll just want to keep on that trajectory, specifically since you mentioned, importantly, that there's need to highlight the massive underreporting and the lack of homogeneity in the research process towards gender-based violence. And at this juncture, I'd like to come back to you, Sally, and specifically just drawing from your presentation, you mentioned that there are limited efforts and inadequate indicators to monitor gendered workplace violence. So I'd like if you could just share with us your thoughts on some of the research priorities for tackling the root causes of workplace violence in the PHC workforce. Over to you, Sally.
Yes, thank you so much, Arthur. So before I go straight to what you have just inquired, I would also like to emphasize that to me, I think it depends on who has power and the voice to make decisions. Because at the primary health care, like in our experience, you see that most of the structures, like the primary health care committees, the leaders of the clinics, the health facility in charges, they are all led by men. So we have very limited number of women, female healthcare providers who are given opportunity to lead these structures and the committees at the primary healthcare and also health facilities. So at the end of the day, that really reduced their voices in terms of making decisions to protect female healthcare providers from gender-based violence. I think this is an area, this is a dimension which is very critical. And because we have very limited representation of women who are leaders at the primary healthcare, different structures, that's why even when it comes to making decisions on specific indicators, gender equality or equity indicators that reflect the extent to which the country is moving towards addressing gender-based violence at the primary health care. We don't have that. We cannot influence having those indicators. You know, sometimes it's very challenging for the country to decide these are the indicators that need to be entered into the routine national health information system. There are a number of bureaucracies that need to be followed, a lot of decisions, a lot of involvement, a lot of engagement. But if we have more women healthcare providers at different structures, different levels, including at the Ministry of Health, at the primary healthcare level, district level, at the health facility level, it becomes easy to influence having this kind of research or the indicators that we are talking about. Because I like about the issue of indicators because it holds people responsible and the people becomes accountable to make sure that important initiatives are in place to be able to contribute towards achieving important initiative to address the issue of gender violence within the primary health care. Yeah. So to me, the issue is who has power, who has the voice in these structures that we are having at the primary health care. Yeah.
Thank you, Sally. Thank you, Sally, for that. I think it's clear. You really highlight and emphasize on power and the importance of voices of women's voices and agency, and in tackling then the bureaucratic processes for instituting the various indicators to tackle this issue. So, without just taking much time, I'd also like to bring on Mamadou. And I was just reflecting back on your presentation. You highlighted the various legal protections in place. And sort of like you painted some grim realities in considering the Burkina Faso context and the examples you provided on what has been happening, the different incidences that really underscore the severity of the situation in Burkina Faso. Just considering your country context, how can stakeholders collaborate at various levels to establish a more effective research agenda for addressing gendered workplace violence? Over to you, Mamadou.
Okay, thank you, Arthur. So I just want to come back to Sally's presentation and just give some figures about the leadership in Burkina in the health sector. So in Burkina, we have 13 health regions, so and 13 directors of health. Now, regional director of health, and only one is a female. This is one figure, and the number has never exceeded one female for the regional directors of health. This is 1 point. And also, when we have 53 health districts in Burkina, and less than 10 head of district are female. So mostly, it's a male-led health system in Burkina. We have at least Directorate for Family and Mother's Health, actually, who is only led by females, but it's recently that they decided that only female can lead this directorate. So when we come to the stakeholders issue in Burkina, it's a very critical context because we cannot go as in South Africa where the violence against healthcare workers, female especially, is acknowledged by the community. But in Burkina, it's not, it's something that is normalized. And even within the community, people think that it's normal to be violent against healthcare workers. So this also brings that if we need to work with them, we need to first work with who are the victims, health workers, female healthcare workers, and within the healthcare system, we need to pay attention to who is going to be represented. We can take the female healthcare workers, but also males, because they are also perpetrators of violence against their peer females. So, and in the trade union, you can also see that in Burkina, we have 2 syndicates like fighting for the right of healthcare workers, but they are led by males. So if we need to work with them, we also need to pay attention to the fact that if they are going to bring representative, we have to have like females represented within this board. For the community, so we have some actually civil society organization who are advocating for violence against patients. So we can work with them. We can also work with visitors and patients. So the patients are not those who are in critical condition, but those who are used to come to the hospitals, we can bring some of them. And also work with community leaders like religious leaders, traditional leaders, village chief, who plays important role. So in Burkina, when you look at the decision makers issue, so primary healthcare setting, mostly the primary healthcare hospitals are led by municipalities. So we need to involve municipalities also in tackling the issue. So when we go to the decision makers at the healthcare system level, so we have an agency that is called like, which actually is concerned by primary healthcare system. And we have the Human Resource Department of the Ministry of Health. So these can be used as entry points to see what are the most relevant stakeholders actually available to tackle the violence against healthcare workers in Burkina. So among the international organizations, we already have WHO. Actually, we work on motivation and redeployment of healthcare workers, who is a valuable partner. We can also add organizations like UNFPA and other NGOs actually working in the workforce. So, but we cannot limit ourselves to that, because at the academic level, you have actually some bodies that are really active, like the Gynecology and Obstetric Society. You have also the Order of Nurses, Order of Doctors, Order of Pharmacists, who are an order of midwives. So we need to work with all of them. So to bring them together, but we cannot bring them together at the same table. So we need to set some groups where people can freely express what is the problem at one stage, and then try to find out within the research community what are the most promising solutions before we can bring some of them together to tackle the issue. Thank you.
Thank you so much, Dr. Mamadou. Thank you so much for those. I think you highlight very critical issues. And I'd just like to continue on this particular theme, because you mentioned inequality in leadership, but you also mentioned very important stakeholders that need to be involved in these conversations. Yeah, I think you highlighted the civil society groups, leadership structures at the community level, quite important, and even trade unions, but them lacking then women representation, which really impacts then what stakeholders can actually bring to the table and how we can go about tackling this issue. So Vera, just continuing on this particular theme, given the formal policies and frameworks that are currently the existing policies, formal policies in South Africa, if you could just share what works so far in terms of best practices for collaborating with the local stakeholders, especially community-based organization, towards addressing such forms of violence. Over to you, Vera.
Thank you very much. So I'm struck by what works and also by what doesn't work. And it's interesting reflecting on how far in some parts of South Africa we have come to ensure that we do have greater representation by women in leadership. So if I think about the area that I work in, the provincial leadership is still predominantly male, but at the next level, or certainly within local government, that isn't the case. Our current director is a man, but the two previous directors were women. And then at the area level, half of us are women. When it comes to the level of facility management, it's by far women who are our managers. And that really reflects the workforce, that the workforce is predominantly women. So of the 23 facilities, so that does make me wonder what else is required, because I absolutely agree. We need to have women in places of power to be able to have these conversations. And yet, when we do have women in places of power with voice, it would seem that we're not actually having the conversations yet that we could be having. So, you know, Sally, in your call for greater representation, I think there's an understanding that with that will only be achieved through empowerment of women. And with that women will then have voice. So I question why in South Africa we have the situation where we are predominantly women, but we're not having this conversation. And is it that we haven't given ourselves the permission? Is it that we are not having the conversation amongst us as women in order to bring these to a higher fora for discussion? I think there's a concern that we might not be able to do anything about it, and that we're opening a box that we will not be able to deal with. That the nature of certain engagements that health workers have are by nature conflictual, and that is accepted. So there's a level of disempowerment that stops us from actually having the conversation, because we don't quite know what we will do when we have that conversation. In terms of what does work, and I'm going to speak at the level again of an operational manager, and some of the opportunities that are there. I think it's to ensure that as far as possible in our use of power, that we are not seeking to engage with communities in ways that we are exercising power over, but that we are actually engaging with communities and seeking relationships that actually speak about power with. And reflecting on our experience that as healthcare workers, a lot of the violence that we experience is because we work with communities, and very specifically, we go to the communities where there is a high level of poverty, a high level of unemployment, a high level of violence as a result of that. We aren't a special case, and we are able to engage with the communities as fellow people, not residents, but workers in that community, also experiencing the violence. So one of the things that we've begun to do in our area is whenever there is a significant incident of violence, is to actually invite the community representatives in to talk about it. Does that prevent the violence? At this point, no. But it is a strategy to assist health workers to actually talk about and come to terms with what they've experienced. And it definitely creates a sense of solidarity, that we're in this together, and it breaks the normalization of violence. It's not acceptable that violence happens. When violence happens, we are actually going to talk about it. So we think about the community very much in terms of our neighbors, because they're experiencing the exact setting that our healthcare workers are experiencing. Then we do have the structures, and you pointed me to some of the policies, Arthur. So we have the structures of clinic committees. We also have the local government structures of wards, ward councillors, and in those ward street committees. And so those are the people that we would engage with at the local level. But then at the area level where I'm based, I would take that to a sub-council meeting to be able to discuss it there. And I would also have it on the agenda with the civil society groups that we meet with. So I think where we're sitting at the moment is exploring ways in which we are able to work together with communities, at least in having the conversation. And then the second point being that in having the conversation, we are breaking this idea that it's just inevitable or that it's acceptable, because at very least, we need to be able to support our healthcare workers by processing psychologically what has happened to them. And that, I think, that psychosocial processing should take place in a relationship of trust with the surrounding community. Thank you.
Thank you so much, Vera, for those great pointers, specifically with regards to, stakeholder engagement and where we need to start, where we need to focus and prioritize some of these conversations. And I think I really liked what you said about, ensuring that power is, we don't practice power over, but power with, in terms of engaging with communities to really, create solidarity and break the normalization of violence. So, and I think at this juncture, it's critical for me to bring on Sally, because it links to one of the questions that was put forward to us by one of the registrants, and just linking on how important community structures are in tackling these forms of violence. I'd like to just, if you could just provide or reflect on how best can you leverage local knowledge frameworks and African indigenous methodologies to inform, such research inquiries and interventions in this area?
Yeah, so thank you so much, Arthur. Yeah, thank you so much, Arthur. Before I go to participatory, because what I'm thinking is that community engagement is very important. And any initiatives that are getting support from the community, it's very strong and it can be very much sustained. Unfortunately, gendered workplace violence, before even we think of engaging the community, unfortunately, gendered workplace violence, particularly in my country, it has not been given the weight it deserves. So we need to make it first a national agenda. When we make it as a national agenda, it will allow mainstreaming of this important agenda in various structures, from the bottom up to the top. If it is not a national agenda, we will minimize a lot of initiatives that are important to prevent gendered workplace violence. So it needs really to be a national agenda, and how we can make it is to make sure that sensitization and advocacy becomes the part and parcel of most of the projects that get the opportunity to receive funds from different funders to spearhead advocacy. Advocacy needs to be part and parcel of the research that we do, not only collecting data in terms of understanding the social determinants of gendered workplace violence. It's really important, but collecting data, coming up with scientific evidence, it needs to go parallel with engagement, several engagement at different levels, at the national level, at the district level, at the community level, so that at least we build a synergy across all things that we do in addressing gendered workplace violence. Without a clear priority at the national level, if it's not a national agenda, it becomes very difficult. Whatever we do, even if we decide to engage the community, at the end of the day, we are guided by the policies. We are guided by the legal framework. We are guided by different structures at the national level. While we embrace the power of the community, conducting participatory meetings, participatory research, qualitative research to understand deeply the dimensions of gendered workplace violence, understanding the profile, what are the types of gendered workplace violence that happens around our healthcare professionals, and how we can mitigate, how we can approach it, but we still need to make it as a national agenda. Thank you so much.
Thank you. Thank you so much, Sally, for those insights again. Once again, I think you highlight, you're very particular in terms of making this issue on gendered workplace violence, it being given a priority in terms of it being a national agenda, and towards limiting the minimization of initiatives and efforts towards advocacy to address this issue. And also thank you for mentioning the participatory action research approaches as being critical towards also taking in and appreciating indigenous knowledge. So at this juncture, I think our time is so much spent, and I'd like to just bring us to addressing some of the questions that are coming in through the chat. And Asha, if you don't mind me bringing you on right now, and I don't know, one of our wrap-up, I think as a wrap-up question for our audiences, and I think this covers a lot of the questions that are being posed. How do we then ensure that we tailor a research agenda that accounts for the diverse structural and contextual differences in the different African countries as we're talking about a research agenda towards gendered workplace violence? Over to you, Asha.
Thank you, Arthur. And I'm just delighted with the engagement in the question and answer and in the chat function. The panelists have been great. It's almost like 3 streams that are converging at the same time. So it's hard to keep pace. I think what's key, this is obviously I'm a health policy and systems researcher, but I really think this is a call for embedded research. And you've heard from Sally the need for policy engagement. Mamadou flagged professional associations. Vera and Sally also flagged community engagement. There are many starting points. There are many different dimensions. And I think it's really key that this goes beyond academic studies. It's great to have the scoping reviews. We need evidence in academic journals to drive change in some areas, but we need also the engagement with specific bodies that have the mandate to respond. And so that contextualized response comes with, for instance, the perspectives that Vera has as an area manager. They're the ones actually facing this problem. Professional associations, what does it look like in their particular cadre that they're responsible for, and develop the research agenda with those key stakeholders in those contexts so that it speaks to the particular vulnerabilities of community health workers. I mean, it was really telling in Vera's, here in South Africa, we have a nurse-led health system. There are women in charge, but there's a lot of abuse between the head nurse and the junior nurse, because you're working in a system that has ingrained power hierarchies that is also going under structural adjustment, massive resource constraints. People are expected to deliver in varied healthcare services and be caring in systems that are not caring. So we need to really look at, in each context, do an analysis of what are the barriers and really work with the local stakeholders to understand workplace violence, but also the gender dimensions. I think there's more and more recognition of workplace violence, but as we can see, we're in the chat and others, understanding the particular vulnerabilities and why we need to include a gender lens. Still, we need to make that explicit and communicate how this is going to make programs more effective if we really want healthcare services to deliver. Thank you.
Thank you so much, Asha, for those great pointers right there. And I think now that you mentioned policy, community engagement, and involvement of other bodies, including CSOs and other community-based organizations, in really tackling and understanding what are the vulnerabilities of healthcare workers, especially in the PHC, at the primary healthcare setting. And I think you also mentioned the inclusion of gender lens in programming to address these forms of violence. Vera, I think I'd like for you to help us probably respond to two questions. If I may just put them together. There's a question here where a participant asks, are female healthcare workers disproportionately targeted due to their gender? That is in terms of gendered workplace violence, or does abuse occur simply because they are the majority of the primary healthcare workforce? And just to tag along a related question is that what strategies then could be put in place to address masculinities, toxic masculinities within the healthcare workforce, and to encourage that can encourage male leadership to actively promote gender equality. I don't know whether those questions were clear. I just wanted to, merge the two together. So one speaks to a female just disproportionately targeted due to them being the majority of the primary healthcare workforce. Over to you, Vera.
Within a patriarchal society, I think that that women are disproportionately affected because we're not recognizing the patriarchal ways in which women are experiencing violence. So the patriarchal society will normalize certain experiences that women have and not actually see that this is unacceptable. So definitely within our experience, sexual violence against women, intimidation is not actually recognized. It will be spoken about as a difficult client, and we all have to deal with difficult clients. So in terms of what that then means when we begin to understand that the experience is gendered, we then do need to begin thinking about strategies to actually support women, because yes, we do work in a patriarchal society. Can we change society? And absolutely. And I think that's what Sally's talking about in terms of an advocacy agenda and the need for us to actually find our allies and to build that agenda, as well as raise it with the particular bodies that have decision-making power to change it. We also need to think about how we equip our healthcare workers to actually engage. So if I think about my own experience as a healthcare worker, I worked a lot in psychiatric medicine, and we were equipped for that. We knew that we were going to be working with patients who had disinhibition, patients who at times could be violent towards us, and as young doctors working in that setting, we were supported to know how to engage, that it wasn't something that we took personally. We didn't take it home with us. My question then is, how can we support women in their work situations? What are the skills that they require to actually be able to navigate the current situation, the current reality, what is, so that they don't take it home? that it doesn't begin to affect their personal relationships, and it doesn't affect their mental well-being. Yeah, I'll let others come in on the next question. Thank you.
Thank you so much, Vera, for addressing those. And I'd just like to, maybe bring on Mamadou back to, issues of masculinity support programs and the importance of recognizing such initiatives. How can we encourage male leadership to actively promote gender equality? And if you can share, if there are any, practical instances or examples in considering the Burkina Faso context specific to masculinity support programs, and whether this can really impact male leadership towards gender equality, linking to addressing gendered workplace violence. Over to you, Mamadou.
Okay, thank you, Arthur. So it's a very good question. And also, I'm happy to share my personal experience and also experience from the National Institute of Public Health. So personally, so when we speak about masculinity, how masculinity can support, so I was actually head of pediatric service in one district hospital with my wife also, but my wife is a medical doctor. We did the same school during the same years, and then we went to the same hospital. So, and then you can realize how violence can be shaped toward female, while me, I'm the male, but I'm not facing the violence. My wife was facing the violence. And sometimes I had to even come back to come to the stage and say, okay, what you are doing is wrong. So you stop to the patient or the relatives, or else I will do this, this, and this. So it's like you have to, the male has also, the male, you have to recognize that violence is there. And men are not facing the same type of violence like females. So the males, mostly the violence can limit to some kind of verbal violence or limited verbal violence. But for females, you have sexual harassment within the context. So how do you deal with that as a leader, as a male leader? You have to set the rules, internal rules, and also say that these are the rules of the relationship between staff. So sexual harassment, any comment of sexual orientation shall be banned in the service. Any type of jokes that really takes the woman out of a context of nurse or medical doctor or pharmacist to just a female has to be banned. So, and then in actually the National Institute of Public Health and within my department where I'm working with, we actually did a gender analysis, which is ongoing, and to see how gender dimension can shape the relationships and the performance of workers within the organization. So, and this is led by a female, like actually by my wife. She's leading this study. And we realize that there are structural differences, commodities. When you look at the toilet, when you have shared toilets, it's a kind of violence because women are not using the toilet the same way as male are using. Women are not using the equipment the same way are also male are using. So these structural differences that are there can be managed even by male leadership. Also, the relationship between the worker system, the workforce has to be managed. And then you come back to what is really the most important thing when you are working. We have a common objective that you are targeting, and how you can now put the leadership, share the leadership so that males and females are equally represented and also have equally voices, not giving more voices to men rather to females, and also not giving too much voices to females depending on males. So this is the way that we need to manage it within the male dominant system, that we can at least reduce the violence. But you have to acknowledge that women are facing more violence with being physical, verbal, or sexual. And even in the Burkina context, the sexual violence is sometimes mostly predominant, but some tend to confound it with verbal violence, because if you are making sexual comment toward a female, it's a kind of violence. She has not come to work because she needs to have a date. She just come to work. So, and then you are trying to date her, she's not listening, and you are doing, and she has to obey because she's a female. So all of these are like, I think that we have to set internally agendas on work on that. Thank you.
Thank you so much, Mamadou, for sharing those examples from Burkina Faso, and I think that really does shed light on that particular question. And just to highlight, I think Asha had it posted in the chat that also patriarchy also shapes power relations, and they need to then have an explicitly feminist lens to unpack some of these intersectional drivers of inequality and possibilities then for transformation. And I think I just want to bring Sally back briefly. There's a question here that is specific to research. And really, if you could just help us maybe understand how can institutions balance permissions for sensitive workplace harassment studies while addressing then some of the ethical concerns that might come along with such kind of studies, which might then restrict, data collection from approving institutions. I think the issue is, these are sensitive studies, and they with the likelihood of, impacting either mental or psychological, the mental and the psychological health of those who are survivors of gendered workplace violence. But then how can we navigate the balance of obtaining permission for sensitive workplace harassment studies while addressing then, keeping to the ethical concerns? Sally, let me just bring you on right now. Yeah, thank you, Sally.
Yeah, sorry. I may experience a bit of power cut, but let me try, given the battery that I have. So quickly, I think Masuma Mabdan, I think one of the attendees mentioned that we really need to make sure that we have a very good representation of women in the institutional review board. The ethics committee needs to have a good representation of women to be able to embrace the importance of addressing this sensitive studies and getting approval from these bodies. If we have more male dominance in these committees, it becomes very difficult for them to have gender lens to be able to embrace the studies that we are submitting. And also another important thing is that we need to declare in research, you need to declare about any sensitive issues that may perhaps cause psychological disturbance to the people that you are going to deal with, or you are going to interview, or the people that you are going to engage in some particular interventions or something. All these declarations need to be done in the protocol or in the proposal, and making sure that we show more or less like the benefit, that the benefit of this study outweigh the risk that we envisage in the study. In that way, we are able to have more or less like a convincing argument to be able to get the approval that we need. Thank you so much. That was very quick.
Yeah, thank you, Sally. Thank you, Sally, for that. And Asha, I think I can just bring you on at this juncture.
Yeah, I just wanted I think there's a lot to learn. Obviously, I'm a researcher, but I think we have a lot to do as a community. So it's wonderful I hope everyone who's joined the webinar, we find a way of staying in touch, because I don't think we need a specific ethics. There are key challenges doing this work that are different from doing other types of public health research. So there's a lot of guidance from the RESPECT guidelines from WHO on trauma-informed research. How do you do research of this kind? But you're doing it within organizations that are part of the problem. That's different from a little bit different from trying to understand the extent of gender-based violence in the population. You are seeking permission from organizations that are part of the problem. So I think we need to think about how do we develop, apart from the ethics, the IRB, which is a challenge, we need to think of the policy engagement. How do we report the findings in a confidential manner? But also when you have cases that have reported to you in the context of research, even with the issue of confidentiality, there might be cases that you have to, what are the ethical responses of researchers? There might be cases that need to be reported out, apart from, there's so many dimensions of this. The victim, the survivor might need referral services, but also there might be instances where we can't be quiet. So we need to think through the implications of this and who are the voices, who are the allies within the system that help us navigate the results and the findings so that it lands to support further change rather than a report that is shelved and that is uncomfortable and the decision makers set it aside as something they can't confront and address. Thanks.
Thank you, Asha. Thank you so much for that. And I think we are left with about 7 minutes, and I think a lot of the questions that were put in the chat, we've gotten to address some of those questions. I mean, our panelists have gotten to address some of those questions, and I'd like to just say, as we wrap up this webinar, very sincerely, I'm sincerely thankful to the speakers and for the participants for providing your insights and your questions and for your contributions. And while there isn't really enough time to recap all the key takeaways, I think it's important. It's been highlighted quite strongly that there's need for policy engagement, and the need for multi-stakeholder engagement towards tackling this form of violence that is gendered workplace violence. And I think also Sally really pointed out that across, looking at the African context, it's important for a push for these efforts and initiatives to be made a national agenda. And I believe the perspectives shared from both, from Tanzania, Burkina Faso, and South Africa have really given us an in-depth understanding of the drivers of gendered workplace violence in the healthcare settings. So I wouldn't want to take much time, and I'd want to check with some of our panelists whether there's any burning concern. Even though I'd like to also pinpoint, there's a question that was put in the chat, not really a question, but a comment. And I just thought to read it out, that I think one participant also mentioned that higher incidence of violence in the health setting is not necessarily unique to the nature of the work that is being undertaken by the healthcare workers, but it really does mirror, what is happening majorly broadly in the society. And I think that's a very critical point. And just before I hand it back to Asha, I'd just like to remind us that that we hold this particular discussion at a time when we are really commemorating the 16 days of activism against gender-based violence. And so let us just remember that all our collective responsibility that we share in addressing workplace violence would really advance gender equality and ensure safety and dignity of all health professions, primary healthcare workforce inclusive. So with that, I'd like to just then pass it over to Professor Asha George to officially just bring this session to a close. Thank you all once again.
Thank you, Arthur. And thank you, Arthur, for being such a wonderful chair in bringing us together and fielding. It's been wonderful to see the inputs from colleagues, the sharing of resources. We would love to stay in touch as this work evolves. I think there's a lot of interest, and for us to have collective impact, to create a community of learning and for us to share resources so that we develop a common understanding to strengthen our responses locally. I think our speakers spoke at the many different levels of action we need, from policy to professional associations, to managers, to community members. And I think we talked also about the challenges of evidence in this area, how we need specific methodological attention to how do we safely document these experiences and communicate them in a way that will lead to policy and program change. There was also discussion on changing the normalization. Fundamentally, yes, health workers, there is this, Arthur, you said there's violence, and Vera said in each context it's different. In Burkina Faso and in certain parts of South Africa, there's a lot of violence in the community at large as well. But there are also, in addition, specific vulnerabilities that healthcare workers face, particularly because they're looking after people who are not well. And I think there's a gendered expectation that women are meant to be caring. And when family members receive care that is not responsive, who do they let their frustrations out? It's easier to let their frustrations out on women health workers who are more available, but also it's normalized that there are no consequences for yelling and physically abusing women health workers. That is part of the gendered bias in this area. So I think our work we have our work cut out for us, but just because something is difficult doesn't mean we don't address it. And I think there's a huge potential for change as we work together to break the normalization of violence in the health workforce and to really work together to make this as one part of societal transformation. I really want to thank everyone. We're 2 minutes to closing, but I know everyone it's a very busy time. We're really grateful that you joined, and please stay connected through the Gender and Health Hub. There's also a link to the African Community of Practice on Gender and Health. And stay tuned. We might think of other ways to stay in touch, particularly on doing work together on addressing gendered violence in the health workforce. Thank you, everyone. Thank you, Vera. Thank you, Sally and Mamadou. Your insights were really wonderful. We really need more contextual, specific examples of how we can support what the issues are and how do we support change. And thank you to all the participants. Look forward to staying in touch.
Thank you, Asha.